Hello guys, in this video we are going to discuss briefly which are the main available techniques for repair of macular hole. There are a few of them. Let's start with the standard vitrectomy plus ILM peeling. This has been a standard technique for several years for patients with small to medium size and primary macular holes. Closure of vitrectomy with detachment of hyaloid and ILM peeling has been achieved in over 90 or 95% of the patients. The second technique is vitrectomy, ILM peeling with a flap, or the so-called inverted ILM flap technique. This may be an optional surgical technique for treating large macular holes and myopic macular holes with pretty high closure rates. In the inverted ILM flap technique, after core vitrectomy and dye staining, the ILM is not completely removed from the retina, but is left in place, attached to the edges of the macular hole. This ILM remnant is then inverted to cover and fill the macular hole, followed by a fluid air exchange. Several mechanisms have been proposed to explain the tissue repair that occurs following the use of ILM flap technique. ILM may possess Macular cell fragments, which may cause glial cell proliferation and allowing macular hole closure. ILM may also play a role as scaffold for tissue proliferation, creating a microenvironment that encourages correct photoreceptor location and improvement of the surgical outcomes. ILM flap may also induce the detachment of the edge of macular hole, allowing closure. The third technique is amniotic membrane graft for treatment of chronic and refractory macular holes. Amniotic membrane graft may act as scaffold for healing of anterior segment tissues like cornea and conjunctiva, but may also have similar role in macular hole repair. Amniotic membranes may mediate gliosis and may have anti-inflammatory or anti-angiogenic properties to support retinal pigment epithelium growth and glial cell migration and hole closure. The amniotic membrane may be placed on the epimacular fascium rather than subretinal placement, given that glial cells may migrate across the amniotic membrane scaffold in an epimacular fashion to achieve hole closure. This technique we're going to talk now is so-called autologous neurosensory retinal transplant for repair of refractory macular hole that involve free flap of autologous neurosensory retina that is harvested and positioning over a refractory macular hole to serve as a plug for the hole and a scaffold for glial cell proliferation. Autologous retinal transplantation for closure of refractory macular hole may work in up to 90% of the eyes. In eyes with anatomic closure, visual acuity improves in about half of the patients. Perifoveal relaxation, the final technique, means detaching the edge of the hole and the hole may close. This effect may be created with massage of the edge of the hole. Second, other option, with the injection of perifoveal subretinal fluid, or if a graft is placed on or under the edges of the hole, detachment is achieved. So in summary, there are a few options for treatment of large and refractory or secondary macular hole that one should know. I hope you enjoyed this video. See you on the next time.